think everyone is going to be shocked for the time and not for the cases. Anyway, another patient with a very bad presentation, 53 years old male, hypertensive, hyperlipemia, no smoker, presented with typical chest pain, dizziness, and headache. Initial ECG showed a ST elevation in inferior leads with the reciprocal change in anterior. Was transferred to our center for urgent coronary angiography and possible PCI. Upon arrival, the patient was stable but suddenly developed a ventricular fibrillation. One single DC shock, 150 joule, restored the rhythm, and the urgent CAG was done and was showing a triple vessel disease, including a CT of LAD. So was decided for mechanical circulatory support insertion due to cardiogenic shock, and the ECMO was inserted. I will jump the description because you are more expert than me. This is the angiography. So total occlusion of RCA, total occlusion of LAD, total occlusion of mid-left circ, insertion of ECMO after a few minutes, ballooning of RCA, distal embolization of the clot from RCA, multiple thrombus aspiration passage with catheter were done. Distally, the flow was very bad. Proximal stentive RCA was attempted, but the TIMI flow was not fine. Again, ballooning. I will make it short. Ballooning of the crux, residual distal stenosis of RCA. But the patient, we know that was still having the occlusion of the left side. So again, kissing, patient under ECMO was stable. But finally, we got an acceptable flow for RCA. So we decided to jump directly to the left. There was a very short attempt to find the lumen in the LAD, but we discovered that was a chronic lesion. So we attempt a dilatation of the proximal LCX, and we restore a bit the flow, even if it was not perfectly successful. Distal perfusion, even here, was done after the PCI. As you can see in the second video that is not going, the first attempt was totally out. This was not done by ultrasound. Again, finally, we got it, and was a good distal perfusion. The flow was low because of the ECMO. So the patient was not going. Okay. The chest X-ray after was very bad. Even the ultrasound showed a very big impairment of the anterior wall. Hypokinesia inferior. So PCI was done by ECMO, as I told you. Proximal RCA, distal RCA stented, proximal left circle OM stented. It remained the LAD. So after 2 days, we decided to move the patient back to the cath lab to remove the ECMO. We checked the RCA, that was fine. Swan guns still on site. As you can see, the left circ, we restored the flow, but still there is distal lesion. So the operator decided to do even angiography of the lima, as our cardiac surgeon requests every time, for possible, let's say, complete the revascularization with the lima. So with a contralateral approach, we put the wire distally in the right superficial femoral artery. We did our ballooning. There was a lot of clot here at the insertion point. We did different dilatation, but finally we found an extravasation exactly at the bifurcation. We did a lot of different projection, and we discovered that there was a big laceration of the artery. Considering the site of the laceration, we didn't consider the cover stent. Even if we try with the manual compression, we try again with the dilatation. So at this point, as we are calling the ECMO team for the insertion, we are even informing the ECMO team for the cannulation. And here the cardiac surgeon, the vascular surgeon, decided to open to repair the femoral artery. So anyway, from the clinical point of view, the patient started with 10% of ejection fraction. After procedure, in a few days, it jumped to 31 of ejection fraction. The echo even was much more better. We decided to do MRI for the further step about the LAD. And we found that the territory of the LAD was not showing any viable myocardium. So after the our team discussion, we decided that there was no space for surgery, so even for the left circ and the LAD. And the patient was discharged with a better X-ray, was discharged for optimal medical treatment. The medication discharge was DAPT, statins, RAS blockers, beta blocker, diuretics, and all the medicine for diabetics. So the patient was discharged with the full clinical status. So teaching point, ECMO-supported PCI enables survival in shock ventricular fibrillation patient with multivessel disease. MRI is essential for viability assessment in revascularization strategy. In patients with extensive transmural infarction, OMT may be preferred over LAD PCI. I try to be very fast. Thank you very much.